If you're sick of COVID-19 and all the lockdowns, or having to wear a mask that keeps fogging up my glasses like this, you're not alone. But with the virus spreading out of control in many parts of the world and surpassing 10 million cases in the US alone, we're running out of patience for a COVID vaccine. Just exactly when is it going to be ready? What would the distribution process look like? For some answers, we're back here at the International Vaccine Institute. If you remember, we visited IVI about 5 months ago to have a chat with Dr. Jerome Kim, Director General of IVI and one of the leading vaccine experts in the world. I'm sure Dr. Kim has a lot of updates to share, so let's go and hear what he has to say. Good to see you again.
Great to see you again. Always nice to chat.
It's been 5 months since we last spoke.
It's gone by very quickly.
Yeah. COVID-19 it's still here. Things are getting worse in many parts of the world, including in the US. So we're hoping that you can provide us with some updates.
I'm happy to try.
What have you been doing at your end?
So, IVI is continuing to work with companies to try and advance COVID-19 vaccine development as quickly as possible. There's Inovio, which is an American company, and we're in discussions with other companies as well to see if we can participate in some of the what we call phase 3 testing of different vaccines against COVID-19. So it's been very busy. We've been writing applications and talking to people to try and put things in order to really get something over the finish line as quickly as possible.
Just for people who may not know who you are, could you briefly introduce yourself?
So my name is Jerome Kim. I'm the Director General of the International Vaccine Institute, which discovers, develops, and delivers safe, effective, and affordable vaccines for global health. A retired military officer. The U.S. Army, which most people don't know, has developed a lot of vaccines. And I have worked on HIV vaccine development for most of my research career. My background then is really in vaccine development, but I've also run a number of different kinds of laboratories, one that looks at something called neutralizing antibody, that is proteins that bind to and inactivate the virus. I've run a cellular immunology laboratory and a sequencing laboratory. So I have a lot of expertise, but I'm not an expert necessarily in all of them.
How many years have you been doing this?
So I started doing research in HIV in 1987, but it wasn't necessarily on HIV vaccines. HIV vaccines started in 1991.
So fair to say you have many, many years of experience.
Few decades.
Few decades. That's comforting to know. I suppose for people who are still not kind of familiar with the distinction between a cure and vaccine, how would you describe the difference between the two?
Vaccines in general prevent infection, or actually more correctly, probably prevent disease. Preventing infection is also important. Not all vaccines do it. Many vaccines will just prevent the disease from manifesting itself fully. Cures, so drugs, can be used to treat infection. So once you have an infection, you can take a drug that will make the infection go away more quickly, improve the outcome. And for COVID-19, we are still in the process of developing effective, safe, and affordable treatments that will allow the disease to go away more quickly. So for instance, people are using a very old drug called dexamethasone, which appears to decrease some of the body's overly exuberant responses to the virus. President Trump got dexamethasone. There's a drug that was approved by the FDA called remdesivir, which appears to have a direct antiviral effect, although people dispute whether its effect is as great as we had hoped initially. There are other drugs that are in the pipeline, but none have really kind of moved to the front yet. I mean, to the front in the sense that this is clearly going to be a silver bullet that really does a great job at getting rid of the disease. Nothing analogous to the drugs that we have for HIV, where we went from basically what was a disease that was nearly untreatable to 10 years later having drugs that effectively reduce the level of that viral growth in the body to zero. We don't have anything like that yet for COVID, but we've only actually known about COVID for 10 months, which is really amazing.
Because President Trump got this like a cocktail of treatment, people seem to conflate the two between whether that was a vaccine or a treatment. That's not a vaccine, right?
Correct. So what the president got when he came down with COVID-19 infection was a mixture of a variety of different things. He got some things like vitamin D, which are not necessarily shown to protect, but which we think may have a protective effect, probably not very harmful. He also got remdesivir, which is an antiviral, so something that may decrease the growth of the COVID-19 virus. He also received a special kind of cocktail of what we call monoclonal antibodies. So, you know, your body makes antibodies against COVID if you acquire infection. Antibodies are proteins that are made by a particular cell of the immune system, and they're very specific. They recognize COVID-19, but they won't recognize the influenza virus, for instance. So if you had COVID-19 infection, you'll develop these infection-fighting proteins called antibodies. What we can do now in the laboratory is to develop very, very specific ones. So what your body does is it makes a lot of different antibodies. What we can do now in the laboratory is identify the ones that are the best, that appear to be the best at neutralizing, inactivating the virus, and we can grow them up in these giant steel vats. And companies in Korea, like Celltrion and Samsung Biologics, are actually among the world's leaders in the manufacture of these proteins. So actually, I think 50% of the world's monoclonal antibodies actually come from Korea.
Interesting. So do people have access to that yet?
So no. So these monoclonal antibodies are available on a research basis only, so in clinical trials. The president got a special exemption, I think one of very few that were issued for the use of this vaccine, for the use of these monoclonal antibodies, because he was the president, or is the president of the United States. And you know, they wanted to do everything possible, so they kind of threw the kitchen sink at it.
Let's look at the timetable for clinical trials and whatnot. Are we actually going to get a vaccine first, or are we going to get a treatment first?
So remdesivir has been approved. Whether and how
Health Scholar's new ACLS virtual reality simulation training virtualizes stable, unstable, and
effective it is at controlling virus growth is still a source of some debate. We probably will hear in November or December about at least one, maybe up to 3 of the different vaccines. And what we'll have is what we call interim analysis data. So when you do a big trial involving 30,000 or 60,000 people, you design the trial so that you're allowed to peek at the data. And this is actually done very strictly, and actually you take something called a penalty when you look, because you know the statisticians, the people who look at the numbers, really don't want you to peek too often, because it impairs the ability of the trial to really understand how the vaccine is, or if the vaccine is protecting. So the first of those interim analyses should become available this month or next month. And what it'll tell you is, based on a relatively small number of people, whether the vaccine is protecting against disease or infection and is safe. Now, on the basis of those data, a company could go to the Food and Drug Administration in the United States or to the EMA, the European Medicines Agency, to ask for emergency use, or conditional use, I think is what it's called in the European Union. And that will allow them to start giving the vaccine to more people. And depending on how it's structured, it could just be, you don't have to sign a consent to get the vaccine. You may just, you may actually get a piece of paper that explains to you that this vaccine is still experimental, we're still collecting data on it. If you become sick, you need to let people know that you received the vaccine so that we can monitor if the vaccine is working.
So is that considered like part of the trial still?
Emergency use would not be within the trial. The trials would continue.
Right.
Until a more definitive answer is obtained. And a more definitive answer would be, you know, the Food and Drug Administration, the WHO have set very strict criteria for whether the vaccine is working. And so licensure in the United States will be based on having protective effect against infection of greater than 50% and having a lot of confidence that that is correct. That is actually the standard definition that the FDA uses for other vaccines. Whether or not they allow emergency use to proceed with less than that information is a possibility, and one that the FDA has openly spoken about. The one caveat that they put on it is that they wanted to have at least 2 months of follow-up information for safety on the average for everyone in the trial, which is very important because they're saying, okay, we understand there's a huge pressure to have a vaccine. especially one that's been shown to be effective, on the one hand. On the other hand, our job, they're saying now, speaking as the FDA, they're saying our job is to make sure that it's not only effective, but that it's safe. So we want to have at least 2 months of safety information. Other organizations are doing something called a rolling review. So the EMA, the European equivalent of the FDA, is allowing companies to submit data as it becomes available, so that the EMA can now review data in real time. Other organizations are considering that. You know, the Chinese have an FDA equivalent called the NMPA, and I think they're expecting to potentially see data from the companies in December. So Chinese, American, European, a lot of regulatory agencies are looking forward to seeing the first hint that a vaccine may be protecting or not.
I think the reason why people are so anxious, or even like the emergency use that you talk about, is because COVID cases are just like getting out of control, especially in the US. I mean, do you see it the same way?
Yeah, so, you know, the US is now in its third wave. I mean, there was the first wave, there was the wave over the summer, and now there's a wave that's even higher than the previous ones. In Korea, you've seen a different kind of, you've seen explosions, outbreaks, but the government in general has been able to suppress the outbreak back down to less than 100 cases usually, although they're still struggling with that now. But you know, when you think about Korea with 99 local infections, I guess yesterday, with 51 million people.
That's pretty good.
That is pretty good. You know, it's been difficult because I think, you know, when governments released some of the requirements, people went out and they did what people normally do. But we have to continue to message, and we have to continue to emphasize that the things that protected you, the things that will keep countries out of lockdown, the things that will allow you to have economic freedoms, or the freedom to move around and do things, masks, distance, and hygiene. You know, if that's the price of being able to do the things you want to do, I think in Korea, people accept that.
Mainly in Asian countries, people accept that.
Asian countries, maybe Australia, New Zealand, a very few other countries. But, you know, I think when you look at the UK, which is undergoing a series of lockdowns, or Italy, where certain regions are under lockdown now, you wonder what the trade-off is and how countries are going to decide what the appropriate balance of, you know, economic freedom or mandate around mask wearing, around hygiene and distance. And you know, it's funny because even in Korea, I mean, you walk out on the street and people are wearing masks. You know, the masks are important, distance is important, and you know, you know, you have to keep it in your mind all the time. Am I protecting myself?
That's why people are like looking for this vaccine to put an end to all this. And when we spoke 5 months ago, you said that things are progressing at a lightning speed. This is like the fastest that anybody's ever tried to develop a vaccine. Is this still the case?
So a vaccine from scratch, you know, the annual flu vaccines are developed over the course of, you know, 6 months, 6 to 9 months. So, but that's a vaccine that we're familiar with, a vaccine for which you know, the regulatory agencies accept lab tests. You don't actually have to do a trial in 30,000 people. But starting from scratch, we've moved at unprecedented speed, and if those vaccines are shown to be protective this month or next month, then that will be remarkable progress. And you know, we've made remarkable progress in other things too. I mean, there's an international consortium led by WHO, Gavi, the Vaccine Alliance, and CEPI, which is trying to put together agreement on getting 2 billion doses of vaccine and distributing it to 190 countries around the world. 20% of their estimated supply will be provided by this thing called COVAX. I mean, we've never done that before. I mean, if we can do that, that would be a really remarkable triumph of internationalism over what we call vaccine nationalism, hopefully. These vaccines that were developed under what's called Operation Warp Speed, the US program, will be available for use in COVAX. I mean, some of the companies have already committed, not all of them. China has joined COVAX. Right now, the two big standouts are the United States and Russia. So, you know, if President-elect Biden is listening, he should join COVAX and join the international effort as well. Because, you know, really, there are data now, modeling data, that would say that, you know, if the high-income countries, and Korea is one of the high-income countries, but European countries, the United States, Japan, Australia, Canada, if they are to purchase the first 2 billion doses of vaccine as it becomes available and don't make some attempt to distribute that vaccine fairly according to the needs of, global needs for COVID, the number of deaths from this pandemic will double.
Wow.
And bringing it under control will become less efficient. Because if you're only taking care of yourself, the epidemic can continue to rage in other countries.
Right.
And as soon as you open borders and people start to move again,
right,
it'll get reintroduced. And I think the other thing is, the vaccine is not going to be something that works immediately, right? I mean, it has to be made, it has to be distributed, we have to get people vaccinated, and it'll take some time. And as that is happening, there's still going to be large groups of people who have never been exposed to the virus, who are at risk, who could become infected and infect others. So masks, distance, and hygiene are going to be necessary even into the next year, as we're vaccinating, maybe 70 to 90% of the people in this world.
First of all, you said the number will double if we start